Welcome to today's LMS Module Introduction to Voice. In today's presentation, we'll cover the following: voice assessment, understanding how to complete a basic assessment of voice, management and therapy considerations, ensuring that our therapy plans are always evidence-based, as well as a quick review of some resources for your toolkit. I've included here a voice assessment checklist that we should be completing each time a client with voice concerns comes through. This involves a thorough case history, the completion of an oral motor assessment, completion of outcome measures. Now, these can also be self-reported questionnaires, perceptual and acoustic assessment, as well as ensuring a referral to an ENT. Now, moving on to case history. On the slide here, we have a few key components that are needed when gathering a comprehensive case history. First, we always want to make sure that we have a thorough medical history. Now, this also includes our primary and secondary diagnoses, such as a client may present with Parkinson's or post-stroke. And we may also have a lot of voice clients coming through that don't have a clear diagnosis as to why they may be having vocal difficulties. So we also really want to ask about any previous surgeries or procedures they may have had. Usually we want to look at any surgeries that were related to the vocal cords, the throat, or the neck, such as a tonsillectomy or even a thyroidectomy. Additionally, we also want to consider any medication they may be regularly using, such as antihistamines, decongestants, or even medication for reflux or asthma, as these can all potentially affect voice. We also want to look at their history of reflux and allergies as well, as these are common contributors to voice issues. And finally, we always want to check in, as well as our swallowing clients, whether they have any respiratory issues such as frequent colds, bronchitis, as this can impact vocal health. When looking at lifestyle and voice habits, it can be sometimes maybe a little bit difficult to ask these questions, but they are really important for our understanding of their voice. So we do want to check out their tobacco use, such as smoking, alcohol consumption. Is this happening rare occasion or quite frequently, as well as hydration habits? This includes, how often they drink water throughout the day, as well as any regular caffeine intake, as this can also affect hydration and overall vocal strain. We then want to explore occupational history. So what do our clients do for the majority of their day? For our pediatric clients who are not working, this may include vocal use at school or vocal use during sports or any other activities such as singing that they may do throughout their week. For our adult clients, oftentimes we're looking at what sort of jobs do they have. So are they in quite vocally demanding roles such as teaching, singing, public speaking? We also want to consider professions that maybe aren't clearly heavy on the vocal use, such as people who work in trade. Although they may not be talking all day for their role, they may be speaking in quite loud environments surrounded by tools where the vocal demand is quite high and they may be misusing their voice throughout the day. We also want to explore the symptoms that the client has been feeling. This includes physical symptoms, the onset of these changes. It's always great if you ask them if they have any videos from before these symptoms came along, as this gives us a bit of an idea of how their voice has changed over time. We also want to look at vocal perceptual symptoms. Now, we will go into this a little bit more in our perceptual assessment, but it's always good to see what sort of symptoms the client themselves has noticed. We also really want to ensure that we gather any information surrounding what other practitioners are involved. This includes our ENT, our GP, or potentially any other specialist like a neurologist, as this can point to underlying neurological conditions. Some points to also consider that haven't been included in this slide is whether there is a family history of voice disorders or related neurological concerns, such as laryngeal cancer, as some conditions can be hereditary. We also want to ask about any previous voice therapy or treatment they have received. And what this means is that it will give us a good idea of what has already been trialed. Has it worked? Did it not work? And kind of figure out maybe the why. Was it a lack of adherence to their exercise program? Was it that the wrong treatment was chosen at the time? And lastly, completing a case history also allows us a really good opportunity to sit down with our clients and set some goals and expectations. One, it allows us to understand their specific goals, such as having a clearer voice when teaching a classroom full of 30 kids, which can be quite demanding on our voice, as well as gives us an idea of their motivation, which plays an extremely important role in the success of therapy overall. Now, on the screen, you'll see that I've attached a screen grab of our speech pathology voice assessment form. Now, this can be found on our clinical drive. However, I've also attached a link at the end of this presentation. Now, moving on to our oral motor assessment. Now, when completing a OMA, it forms a really important part of our assessment as it allows us to identify any structural or functional abnormalities that are present. This may include their jaw alignment, looking at tongue strength or weakness, as well as any difficulties with their articulation or tongue coordination that could potentially affect vocal production. We also want to assess for excessive tension in the oral muscles, which is a very common feature in individuals who present with muscle tension dysphonia. Now, this can contribute to strained or tight voice quality and affect vocal fold vibration. Another reason that it's really important to complete an OMA throughout this process is because poor oral motor function can influence the resonance of the voice. For example, we may notice that a client who presents with difficulty with the movement of their soft palate may lead to issues such as nasal resonance or hypernasality, which impacts the overall vocal quality and how they're perceived. And this can help us identify this quite early into the assessment process and give us a bit of an idea of the therapy plan that we may want to implement. During your OMA, you may want to take this time to also complete an S to Z ratio. For anyone who may not be familiar, this tool is used to differentiate between laryngeal efficiency and respiratory support. And during this assessment, we want clients to score between a 1 or close to a 1. Again, take this time while you're completing your prolonged R during the OMA to also complete a maximum phonation time, and this just provides insight into our client's ability to maintain their breath support, which is really important for our speech production, both at single level, sentence level, and at spontaneous speech production. We have also included some norms at the end of this presentation for you to use, just to compare in regards to age and gender and where they should be at. Now, moving on to outcome measures, I have specifically included some self-report questionnaires on this slide. Now, I really want us to be thinking about why we should be using self-report questionnaires during our assessment process. Now, using something like the VHI or the voice symptom scale is really important as it provides us really valuable insights into our client's perception of their own voice and how it impacts their daily life and well-being. Now, as we know, this is really important as it gives us a holistic view of the voice disorder and not just what we've collected clinically. It allows us to capture subjective experiences such as any emotional distress related to the voice disorder, difficulties with social interaction, and any functional limitations that have resulted because of this. And when we're doing our clinical assessments, these sorts of difficulties may not always be apparent. So that's why it's really important that we complete these. They also allow us to identify specific areas of their vocal difficulties that may not be very apparent to us, such as vocal fatigue. So how they use their voice, maybe you see them for a session in the morning and their voice is quite strong. It doesn't tell us how their voice may sound like at the end of the day. It also allows us to get a bit more information about how they feel speaking in a noisy environment, such as at a cafe or at a restaurant, as well as whether they're experiencing any self-consciousness about their vocal quality, which may be impacting their quality of life. So have they stopped hanging out with friends or going out to events because of it? Another really important outcome of completing these self-report questionnaires is that it really allows us to understand this client's specific needs and allow us to goal set really well with them, as it gives us the opportunity to figure out what goals are the most important to them. These questionnaires also allow us to track progress over time, as they give us a really clear benchmark to compare pre and post therapy scores. Now, included in the list of these questionnaires is both ones that you can use for adult and pediatric clients. These forms are also available on the Clinic Drive and as links at the end of this presentation. Now we moved on to our perceptual assessments. Now, our perceptual assessments are a very key component when evaluating a client's voice. And we often do this in conjunction with our acoustic analysis in order to just provide a more comprehensive understanding of their vocal function. Now, a perceptual assessment really relies on the clinician's, trained ear to evaluate the quality of their voice, such as their pitch, their loudness, their resonance, and overall quality, allowing us to often put forth a diagnosis or a severity, such as a mild, moderate, or severe vocal disorder. It also really helps us quantify any subjective aspects of the voice that may not be easily captured through objective measurements during our acoustic assessment. Now, on the screen here, I've included 2 perceptual assessments that you can complete, the Grabus scale, and then we'll also look at the CAPE 5. Now, the Grabus is quite commonly used when completing a perceptual assessment. And as you can see, we look at grade, which is the overall voice quality, roughness, so any irregularity in pitch and loudness, breathiness, asthenia, and strain. And I've included a table here on the sort of features that you should be looking for. For anyone who is not confident in completing a Grabus scale, I have included at the end of this presentation a link to the University of Wisconsin website, and they have a voice disorder lab with a number of videos and audio recordings of different vocal qualities, and just give yourself an opportunity to take some time to really listen to those and practice rating them using this scale just to get your confidence a bit up. Another really useful tip is, with your client's consent, recording your completion of these perceptual assessments to allow yourself the ability to listen back to them at the end of the session, just to ensure that you haven't missed anything in the moment. Now moving on to our CAPE V assessment. This is a scale where, as the clinician, will rate different parameters. As you can see, overall severity of vocal quality, roughness, breathiness, strain, and pitch. You don't have to do both the CAPE V and the Grabus scale. It's completely up to you. As you'll see with the CAPE V, there are a few tasks already set out for you. So looking at their ability to produce sustained vowels, A and I, sentence production, as well as a spontaneous speech sample. Again, here's a link for the Wisconsin website for anyone who may not be confident in doing this independently. And again, always really good if the client consents to taking an audio recording, as it'll give you a bit more of an opportunity to refer back to it, or to even get a secondary opinion from either your clinical mentor or a colleague. Now moving on to our acoustic assessments. Now, our acoustic assessments, again, a very valuable tool within our assessment process, and it looks at analyzing voice parameters with software and equipment. So this isn't subjective, it's a very objective measurement of their voice. And why it's really, beneficial to complete this is oftentimes with the trained ear, we cannot determine things like fundamental frequency, jitters, or shimmer present in the voice. So we may use software such as Lingwave or Prat in order to do this. In our acoustics assessment, these are some of the features that we'll be looking for. So our fundamental frequency, which again looks at the pitch of the voice, looking at average pitch as well as the maximum and minimum. So how high can their voice go and how low can their voice go? We want to be looking at the intensity of their voice, so their loudness. Are they able to project in a loud room or at work? Jitter and shimmer. We also want to look at our harmonics to noise ratio, as well as our spectral analysis. Now, for anyone who is unfamiliar with this process, it can feel like a lot, but it is quite simple once you get a hang of it. And again, at the very end of this presentation, I've included both the links to download these programs, and you don't need to have both. You can either pick Lingwave or Prat. I tend to find Praat is a little bit more user friendly, as well as a link to a video on how to complete your vocal analysis. And as again, different ways that you can then interpret those scores to put together a real life picture of that client's vocal quality. Now, one of our very last steps of our voice assessment is to ensure that our client has a referral to see an ENT. Now, if your client has come through to you with a referral from either their GP or they've self-referred and they do not have a letter or have not completed an assessment with an ENT, this is really important to provide them a bit of a breakdown as to why this is an important part of our assessment protocol. And this is because, and I've included a bit of a picture here, we cannot see what is internally occurring during vocal production. We can create quite subjective measures, such as vocal characteristics, such as they have a very rough or breathy voice, but we don't know why that is occurring. An ENT during their evaluation will allow for understanding of what's happening at the vocal fold edge. Have there been any changes to structure or the range of movement? Whether there are any asymmetries or any abnormal physiological findings. So, does the client have any cysts or nodules present? As we can see in this picture, we can see vocal folds at respiration and phonation when there is no paralysis present. Unilateral paralysis, as we can see at phonation, we have one side opening and one side not abducting and ducting as it should. And then at bilateral paralysis, we got very limited opening for vocal production, which may result in a very breathy and low volume voice, impacting how they sound and are perceived by others. So again, really important to have this discussion with our clients. And it also means that we can ensure that our therapy approach is evidence-based and is going to be targeting the most accurate parts of their vocal difficulties, as different therapies will target different mechanisms of vocal production. Now, on this slide, I've included a few different types of voice disorders. So our two main categories are organic and functional. Within our organic voice disorders, we have structural voice disorders that result from physical changes in the vocal mechanism. Now, this might include vocal nodules being present on the vocal fold, or structural changes in the larynx due to aging, and as well as neurogenic voice disorders. Now, this is a subtype of the organic voice disorder, and this often results from difficulties within the central or peripheral nervous system, which may be impacting that vocal mechanism again and the movement. So some of the diagnoses that you may see as a result of this would be spasmodic dysphonia or vocal fold paralysis. We also have our functional voice disorders that result from inefficient use of the vocal mechanism. So this could be vocal fatigue, muscle tension, dysphonia or aphonia, diplophonia or ventricular phonation. Again, it's important to note that ensuring that we have an ENT involved with clients that present with a potential voice disorder, as they'll support us in understanding, the physiological side of things, such as the structural and neurogenic disorders, but will also help diagnose our functional voice disorders. Now moving on to the management of voice disorders and therapy considerations. I've included a link there to the Speech Pathology Australia Voice Guidelines. I find that it's a really nice resource to refer back to when you're unsure of where to go next. It also has some really good resources and evidence-based research articles for anyone who would like to read up a little bit more on the therapy or the diagnosis. And it's also really important to note, as we do with all our other approaches and scopes of practice, is that understanding the specific difficulties your clients are experiencing will really support your ability to implement the most appropriate evidence-based exercises, as each of them will target different mechanisms as mentioned before. So this is where our perceptual, acoustic, case history, our involvement with the ENT is really crucial and beneficial. Now, in this last slide here, I have included just a few examples of areas of concern or voice disorders and some of the therapies or strategies that you may want to consider. For example, one of the most common voice disorders that we tend to work with is Parkinson's. Some of the therapies that you may look at is implementing LSVT loud or speak out loud. If you're not trained yourself, please reach out to a member in the wider team who may have already completed the training, or if you're interested, reach out to your clinical mentor on how you can go ahead with completing that program. We also can look at spasmodic dysphonia. So this is one of our voice disorders where we will work closely with the ENT or the specialist involved in their care, as they may require Botox to support vocal fold adduction and abduction, as well as the implementation of therapy exercises such as the yawn side technique. For clients with nodules or polyps, you may want to consider resonant voice therapy, vocal function exercises, things like such as accent method or even biofeedback. And again, this will range client to client. I've also included a very handy link to something I like to call my voice therapy guide. It's a really beneficial free ebook available online that lists a variety of vocal disorders and difficulties associated with voice, some of the therapies that you may want to consider, as well as additional research that you may want to refer to. So I find that it's a little bit of a handbook for those instances. Lastly, if you do have any clients that present with a voice disorder and have any further clinical questions, it's always really important that you reach out to your clinical mentors as well as the wider speech pathology team on getting some additional support. Again, like mentioned before, here's a list of all the resources that have been discussed throughout this presentation. This includes outcome measures, case history forms, as well as some of the norms and softwares that you can use during your perceptual and acoustic assessment process. Thank you so much for listening to this presentation.